Hello class. We're going to talk about the patients with non-infectious upper respiratory problems. And many of these things that are in your PowerPoint or in your reading assignment really will be issues and situations that we don't always see the patient admitted to the hospital, because some of these procedures that we're going to talk about that are done for our patients are done on an outpatient basis. But many times, because of the complications that occur, namely bleeding and infection or some compromise in their airway, the patient may be admitted to the hospital. And that's where you need to understand exactly what procedure the patient had so that you can hopefully provide him proper oxygenation, make sure that he has an open airway and there's no compromise within his respiratory system. And because of the types of procedures that we're doing, particularly when we're talking about the nasal cavity, fractures of the bone, fractures of the nose, including the bone, and even facial fractures, we always have to think that if the impact was forceful enough to cause a fracture to those different areas, has the patient also suffered from some kind of skull fracture or some kind of neurological problem. So along with assessing, patency of the airway, we also want to be sure that our patients are neurologically stable, because sometimes we see eyesight compromised, or we start to see deterioration in their neural function. So you want to keep that in mind when we're talking about patients that have problems, especially if it's due to a trauma, that they've had some kind of forceful blow. Okay, so just keep that in mind as we go along and talk about some of the things that we might see occur with our patients who have certain kind of structural issues that need some kind of surgical intervention. All right. The next slide is just basically a anatomy of those upper airways. Thinking about all the sinuses, soft palate, hard palate. We're kind of looking at structures such as the nose, the sinuses, the oral pharynx, the larynx, and the trachea. Whether or not these are acute or chronic problems our patients may have been suffering from. But think about it when we're talking about how that air from the atmosphere enters in the body. It is the entrance site for air, our sources of oxygen. So when we have issues with these upper airway structures, you might see your patients have some difficulties with breathing or suffering some other symptoms and manifestations. So that's why it's necessary that they have some kind of surgical intervention kind of implemented. Don't forget too, the larynx. We're going to talk about that when we talk about patients that might have cancer of the larynx, how that really is a very serious situation, particularly if we have metastasizing of the tumor. But this is a very important slide when we think about nursing priority. Major nursing priorities with disorders of the upper respiratory tract is to promote oxygenation by ensuring the patient has a patent airway, and that's pretty understandable. But sometimes we do see some compromise in our patient's airway, and they do have some difficulty in their breathing. So we have to be able to assess that immediately and then intervene immediately. The first one is when we're talking about fractures of the nose. It can be a displacement of either the bone or the cartilage of the nose that can cause airway obstruction or even a cosmetic deformity, and can be a potential source of infection. And we see fractures of the nose occur, and those can be due to injuries such as falls, accidents, particularly auto accidents. With that impact, the head comes down, hits the steering wheel, fractures the nose, or even a lot of sports-related injuries that involve the nose, causing the nose to fracture. But sometimes they might not be that very severe. Okay, if the bone or the cartilage is not displaced, serious complications usually do not result, and sometimes they don't even need any treatment. It might be a little sore, might have some swelling, and one common treatment for that would be just to apply cold compresses or ice to the area, and the person may not even have to go to the emergency room for any kind of treatment. The next one, but when there is a certain displacement of either the bone or cartilage that does really interfere with airway flow, then it's necessary that a person does seek medical treatment, okay? And, you know, you really want to understand, too, that fractures of the nose are probably one of the most common facial fractures and most common fracture in the body, and usually results from a direct assault, okay? And obviously signs and symptoms, the patient's going to have a lot of pain. There may be some bleeding externally and internally in the pharynx. You have a lot of swelling of the soft tissues adjacent to the nose, some maybe periorbital ecchymosis or bruising, possible nasal obstruction, and sometimes you see some kind of deformity result from that, okay? So keep that all in mind when we're talking about, you know, fractures of the nose. And you, like I said before, always keep in mind that we might have some kind of neurological problem too. That's why when we see any drainage come from the nares or from the nose, that we want to test it for cerebrospinal fluid, because that could indicate that your patient might also have a skull fracture along with the fracture of the nose. All right, very important. Then we also have to kind of get in our keen assessment skills to kind of look at their level of consciousness and all the other associated neurological assessments that we need to do on this patient. And like I said, these patients that have these types of injuries will come through the ER, maybe be treated either under local or anesthesia, depending on how severe the fractures or the injuries are, and usually go home the same day. It's only that we see them get admitted into the med-surgical floors because of some kind of complication such as bleeding, or maybe a neurological deficit, or some real serious impairment of airflow, that we are going to see these patients come into the hospital. But some of the interventions that we may see occur is, first of all, a closed reduction, okay? This is where they actually move or manipulate the bones in place. It can be done under any local and sometimes general anesthesia. But they want to do this within the first 24 hours after the injury, and they do this because of edema and scar tissue formation, okay? And if everything goes okay, the patient can go home, treat them with some kind of pain medication. They stay away from aspirins and NSAIDs because that can lead to bleeding, and just encourage the patient to put cold compresses on the area to decrease swelling and you know, in the tissues and that. The next one is a rhinoplasty, and it's a surgical reconstruction of the nose for cosmetic purposes, and it helps to improve airflow. And many times, you know, if the fractures may be very severe, or maybe they've had some kind of closed reduction for a previous injury on a nose that really didn't heal properly, this is another further procedure they might do to kind of prevent any possible deformities, or to definitely enhance airflow movement. What they do with these patients is they'll, you know, usually involves both nostrils. They'll put in some packing in the nares to prevent bleeding and provide a lot of support. Might also give antibiotic ointment with the gauze, such as bacitracin, and they put like a drip pad under the nose, which we call a mustache dressing. The big concerns are bleeding and incredible amount of edema, which can impair airflow. Obviously assess vital signs, particularly watching that blood pressure and heart rate to see if the patient is having some type of posterior nasal bleeding, and we can detect that if we see the patient really swallowing a lot, because that means that's an area that we're not going to be able to control, that the patient's physician or healthcare provider needs to be called immediately. It's an emergency, and they will have to get in there and intervene aggressively to prevent that bleeding. It'd be a good idea, if you suspect that, to open up the oral cavity and check it with a pen light, And if you do detect that there is some posterior bleeding, then it's important you call the doctor right away. Okay. But for the most part, our patients do go through a rhinoplasty as a uncomplicated procedure. The patient usually can go home the same day, get proper home instructions, and those would include, sitting up in a semi-Fowler's position, just moving slowly, taking it easy, resting at home, providing some cool compresses to the area to prevent further swelling and bruising. Make sure that all the reflexes have returned, such as a gag reflex, so that they're able to eat and drink, eat soft foods, limit those Valsalvo maneuvers, avoid coughing or straining. They will be mouth breathers because of all the packing in the nasal cavity, so encourage them not to do a lot of sniffing upward or blowing the nose, and if they do have to sneeze, to make sure that they open their mouth to prevent all that pressure from building up. Laxatives and stool softeners to prevent straining, and again, stay away from any type of aspirin derivatives or NSAIDs to prevent, like I said, bleeding. They may be on antibiotics. Maybe a humidifier may help to prevent drying of the mucosa. And these people that have this done, usually it takes about 6 to 12 months to get those final results that they're hoping for. Okay. But the important thing is to obviously assess airway and to watch for any of that posterior bleeding that may occur. The next one is a nasoseptoplasty or submucous resection. This may be needed to straighten a deviated septum, and maybe the patient's been having manifestations and symptoms for a while with stuffy nose, snoring, recurring sinusitis. And sometimes these people really have a very major septum deviation where it actually obstructs the nasal passages or interferes with airflow or sinus drainage. And they can actually take out the cartilage and then put it back in. They kind of reduce it to hopefully open up that airway a little better. Those are some of the interventions that we may see with our patients with problems with the upper airway structures. And this is what the picture looks like with a rhinoplasty. As you can see, they've got packing in that nasal cavity, and then they've got that mustache dressing. And like I said, it's really important to observe from the nares if there is drainage, because you'll see like a yellow halo with cerebral spinal fluid, because many times the x-rays are not the most helpful in determining if a patient may have a skull fracture. But that's why it's important just to kind of watch your patient also, neurologically. And then the next issue that we're going to talk about is epistaxis, and that's just a fancy word for a nosebleed. Okay, and sometimes we see this as a common problem. And the only time we have to be aggressive with a nosebleed is if they really don't respond to some of the emergency care. But think about it, with epistaxis, most of the bleeding comes from the anterior septum, where you have those 3 major blood vessels that enter the nasal cavity. That's why when somebody bleeds and has a nosebleed, it's a very bloody mess because it's so vascular. And management of the epistaxis will depend on the cause and the location of the bleeding site. Most epistaxis are benign. Treatment is, which we tell people to do, is to pinch their nose with their head tilted forward for about 5 to 10 minutes. That should usually stop the bleeding. If not, then we have to get a little bit more aggressive, and with some anterior nosebleeds, we might use that silver nitrate application and gel foam, or sometimes by electrocautery, kind of cauterize those vessels. There's also topical vasoconstrictors such as adrenaline. Those may be used, and think about it. If the patient has had a lot of bleeding, there might be blood we need to suction out, as well as some of the clots to remove. Remember, it's very scary to have a nosebleed, especially when you see all those copious amounts of blood and bleeding, because there is a lot of blood. And we might want to teach Patients, how to prevent epistaxis. No forceful blowing, no straining, staying away from high altitude. Sometimes the pressure changes will make the nose bleed, and not to be a nose picker, which can cause a lot of nasal trauma. Some of the risk factors of why people get nosebleeds: dry mucous membrane. Sometimes they have a lot of local infections. Maybe it's a sign of a more serious problem like hypertension, or maybe even a tumor. Maybe excessive use of aspirins and liver disease, or maybe some of the medications such as anticoagulants. Your patients may be on medications for other comorbidities like cardiac issues, Coumadin, maybe for atrial fib, or maybe the patient has had valvular surgery, so they need to be on some type of anticoagulant, or maybe the patient had some kind of cardiac intervention with a stent. So could be the medication, that's affecting their PTTs and INRs and things like that, which may cause them to have more frequent nosebleeds. So those are things that you want to think about. But also remember, too, that with a posterior nasal bleed, that is an emergency. And, we note that from the patient when we see that excessive swallowing. So please, please watch that. If you're taking anything from this lecture, that is one thing that I really cannot stress enough. You want to assess for respiratory distress and for tolerance of packing or tubings. These are some of the aggressive types of tubes that the physician may apply to the patient to put pressure on those vessels to stop that posterior bleed. As you can see, quite aggressive, but we've got to do something to stop it, okay? Sorry, I went too fast with those, but those are some of them, along with providing, humidity, oxygen, keeping the patient on bed rest. May want to put them on some antibiotics and some pain medications. This may be very uncomfortable for some people, but it's important that these are definitely applied to prevent that bleeding. And that's what we need to really think about with a nosebleed. What is the identifiable cause of the nosebleed, and then to find out how to control that source. And as I said, the nose has many capillaries, so it's a very vascular area. That's why we see such a large amount of bleeding when a patient does have a nosebleed. But, sometimes it's just a benign kind of just a fluky thing that occurs, but other times it can be a red flag that tells someone they may have high blood pressure, a blood dyscrasia such as leukemia, a tumor, or things like that. Or we see nosebleeds too from people that use chronic cocaine. So you want to kind of watch your patient to see if they have some kind of drug use, or think about NG suctioning or insertion of an NG. So those are different reasons why a patient may experience a nosebleed. Okay. Okay, the next thing we're going to talk about is nasal polyps. Not a real serious situation, but all these are is like benign grape-like clusters of mucous membrane and connective tissue. And just think about it. You've got a little polyp up there. It's going to obstruct the airway in the nares. And it can actually obstruct nasal breathing, change the character of nasal discharge, and change speech quality. The treatment of choice is a polypectomy. Can either be done locally or general anesthesia. And the big thing is to watch for bleeding. They also have packing with gauze for about 24 hours. If they're not completely removed, they can come back again. Okay. They usually occur bilaterally because of irritation to the mucosa in the nose, sometimes due to sinusitis, and they just can be very annoying to the person because their nasal breathing changes, and they might have more discharge from their noses, or maybe they notice that there is a change in their voice, okay? And sometimes they can get large enough where they actually do cause a obstruction. And like I said, if you have polyps, you're at risk for them to return. Sometimes they can provide nasally inhaled steroids and then obviously surgically remove the polyps under local or general anesthesia, okay? So that's pretty much about it with polyps. This is kind of how they look. You can see them up there, how that one on the right looks fairly big, that it's really could cause a fair amount of obstruction. All right, now we're going to talk about cancer of the nose and sinuses. With these types of cancers, the important thing to understand is the onset is slow and manifestations kind of resemble sinusitis. So that's why people really do not seek medical attention. The time when they finally go see their healthcare provider is they probably notice some local lymph node enlargement that kind of occurs on the same side that the tumor is at. The incidence of this occurring is usually in the age group of about 40 to 45 years old, more prevalent in men during those years. For women, it's a little older, 60 to 65% years of age in women. Asian Americans have more of an increased incidence in nasopharyngeal cancer, okay? And a lot of the manifestations are, persistent nasal obstruction, sometimes bloody discharge, pain, and as I said before, lymph node enlargement. Treatment is radiation, but they will try to surgically remove the tumor. Just depends on the tumor size and exactly where it is located, okay? Like I said, these are rare types of cancers, and we see it in people probably that have more exposure to irritants, and obviously people who smoke cigarettes. Usually when it's diagnosed, it's probably at its advanced stages, because like I said, not many people kind of recognize immediately that might be some kind of cancer of the nose and the sinuses, because like I said, it resembles sinusitis so closely. All right, the next one we're going to talk about is facial trauma, and this can definitely be a very serious situation. And as you can see, depending on how severe the trauma is, we kind of categorize what type of trauma the patient has experienced by what particular bones in the face are fractured. A Lefort 1, a Lefort 2, a Lefort 3, and obviously the first assessment is airway. And when we talk about facial trauma, it's always described by the specific bone that's involved, whether it's the maxillary, the orbital, the mandibular, which is probably the most common type of facial fracture. That is our lower jawbone. And as you can see with this Lefort 3, it's a combination of 1 and 2 plus an orbital zygoma fracture, often called the craniofacial dysfunction, because it leaves the midface with no connection to the skull. So that is how serious this type of trauma is. And this is just a picture of where you see those fractures at when we kind of define whether or not they're the 1, the 2, and the 3. You can see how much more severe that fracture is. Obviously, airway assessment is of utmost importance, and the need for possible emergency intubation. These patients may also need a tracheotomy or a cricothyroidectomy, thyroidotomy, I should say, because it just depends on what kind of, assessment findings that occur. Do the patients have shortness of breath? Do they have dyspnea? Do you hear stridor? Are they more anxious and restless? Many times that's just a sign of hypoxia. And obviously assessing color, cyanosis, level of consciousness, looking behind the ears for any extensive bruising. And also with this facial trauma, it's also important to definitely assess visual and eye movement. Maybe some of the cranial nerves have been involved, which may affect the patient's able to move their eyes, or even, are they suffering some kind of impairment in their eyesight. When they're going to, do any kind of repair of some of these, especially the mandibular jaw, they might be wiring the patient's jaw shut to promote healing. It's important that we have wire cutters at the bedside at all times in case there's some kind of issue, that we would be able to cut those wires immediately if the patient's having any type of severe respiratory distress. Okay, so that's a little bit about facial trauma. But again, when we have serious facial trauma, remember, we have to really assess our patient's neurological situation, okay? And also look for soft tissue bleeding, leakage of spinal fluid through the ears and through the nose. And again, assessing your patient's eyesight and eye movement, okay? All right, we talked a little bit about obstructive sleep apnea when we talked about CPAP and BiPAP. We can define obstructive sleep apnea, a breathing disruption during sleep that lasts at least 10 seconds and occurs a minimum of 5 times in an hour, okay? And many times people start maybe suspecting that they might have this because they're not getting into that real deep sleep with those REMs. So they wake up and they have excessive daytime sleepiness, inability to concentrate maybe at their jobs, and they're very, very irritable because they're not getting enough sleep. I think it's important that they find out the origin of the problem, because sometimes sleep apnea can be a neural problem in origin, but we see some of the risk factors with people who are obese, have short necks, large uvulas, or even people that smoke, or even people that have large tonsils. Those people would be more prone to developing sleep apnea. And what happens is, as they quit breathing, they're retaining CO2, pH is dropping down, so they become very respiratory acidotic. And what happens is, when that PO2 also starts to go out, the PaO2 starts to reduce, the brain kind of signals it to, hey, you're not breathing, you need to take in a deep breath, blow off some of this CO2, and get your oxygen levels up again. So that's kind of how we breathe, and this is what we see with these patients who do have obstructive sleep apnea. A lot of times it's the family member who kind of says, hey, you were scaring me last night, you kind of quit breathing a couple times. They might do a lot of sleep studies on these people, some polysomnographies. They'll also do a EEG, ECG, and EMG, electromyograph. So just to kind of determine, that the patient has sleep apnea. These are some of the non-surgical managements where sometimes it should change a sleep position. Really, if it is due to obesity, they will encourage these people to lose weight, or again, use things such as CPAP at night. And works real nice with these patients because it keeps those airways open. This is what you would see. Obviously, somebody using his, CPAP. Okay? All right. Okay, now we're going to look at disorders of the larynx involving the vocal cords, nodules and polyps, and then laryngeal trauma. Okay? All right. First of all, okay, let's go back. All right. Sorry about that. The first one is vocal cord paralysis. And think about where your vocal cords are. And this can be due to maybe trauma, some kind of injury, or a disease that affects the larynx in the nerves or in the vagus nerve. This could happen due to the fact that a patient was intubated too long, prolonged intubation. Sometimes it can be temporary paralysis. Rarely is it permanent. Can occur also with neurological problems. Maybe someone had a chest injury, had some injury to the vagus nerve, brainstem injury. Laryngeal nerves may be damaged from trauma or disorders that involve the chest, the esophagus, and the thyroid. Okay. Usually one is affected, and so hopefully the airway will still be patent, but the voice is affected. So the patient may have some hoarseness, breathiness, and more prone to aspiration. Come on in. I just got done explaining about how manifestations are kind of assessed when only one of the vocal cords are affected. But if bilaterally they're affected, it can really seriously cause a airway obstruction and could be a medical emergency. We got to put the patient in high fallers and call a rapid response. There may be such a situation that the patient does need to be intubated or have an endotracheal tube. If there's an open vocal cord paralysis, it really is a risk for aspiration for the patient because what happens is they don't close during swallowing. So it's recommended that a patient would hold their breath. Okay. For vocal cord nodules and polyps, nodules are enlarged. And what happens is it makes the vocal cords touch during speech. These can be chronic edematous masses. We see this with people who smoke, have allergies, live in dry climates. Also, vocal cysts may occur. So we recommend to treat this. No tobacco, rest your voice, no speaking, not even as much as a whisper, and no heavy lifting. Patients may need speech and language therapy. Sometimes surgery may be necessary, and that would require 14 days of voice rest post-operatively. The last one here with disorders of the larynx is laryngeal trauma. This is a crushing direct blow to the larynx. Could be caused by also a prolonged endotube intubation. And with laryngeal trauma, we would see obviously difficulty breathing, aphonia, hoarseness, even sometimes subacute emphysema around the upper chest and neck area, bleeding from the airway. And what they would do would be a laryngeoscopy, which we'd want to directly look at the larynx to know the extent of the injury. Again, worried about assessment with the airway, might provide oxygen, humidity, and watch for signs and symptoms of respiratory distress. Sometimes if the trauma is very serious, patient may need surgical intervention where they may actually need some type of artificial airway to be able to provide adequate oxygenation. Okay? All right. So the next problem we're going to talk about is upper airway obstruction. And this is anything that may involve an obstruction in the nose, the mouth, the pharynx, the larynx, even tongue edema that can cause an occlusion, laryngeal edema, maybe a huge abscess that obstructs the airway, head and neck cancer. Another thing that you may not consider as a upper airway obstruction would be thick secretions. Sometimes we see that occur when patient has not really had very, very good oral care, and a lot of times secretions really start to accumulate on the roof of the mouth, where if you really don't get in there and assess the status of the oral cavity, then those secretions can really start to build up, and we call that in speciated oral and nasopharyngeal secretions, because it can actually lead to asphyxiation because of poor oral hygiene and thickening and hardening of secretions that can completely block the airway. We see this in people that have are at highest risk for this is nursing home residents, people who are dehydrated, altered mental status, and the inability to communicate, and really people who aren't able to effectively cough and bring up those secretions. So we might see this also in people who have had a stroke, cerebral edema, aspiration, people who've had severe burns, or even anaphylaxis reactions. So just to be aware that any of these upper respiratory structures could result in an upper airway obstruction. So of course the key to this is early recognition to prevent further complications, which could eventually cause a respiratory arrest. And then again, neck trauma. This is any trauma that's caused by a knife, gunshot, or traumatic accident. And I think when you think of neck trauma, you have to think about all the adjacent structures and features in the neck, particularly carotid artery, the esophagus. The priority nursing care for a patient with a neck trauma is to assess for and maintain a patent airway. And you want to look for any other injuries, including cardiovascular, respiratory, intestinal, and neurological damage, especially when we're talking about carotid artery. But you have to understand, if that carotid artery is nicked, that's going to bleed out very quickly, and unless you get the person to the hospital and provide adequate vascular volume and hold pressure on that area, we're going to lose that patient very quickly. Again, talking about the neck, because of the cervical spine, we want to look for any cervical spine injuries and prevent excessive neck movement. A lot of times when the paramedics are first on the scene, they'll get those patients in a type of a neck collar to prevent the patient from moving around. And then talking about head and neck cancer, this can not only disrupt breathing, but eating, facial appearance, self-image, and speech, and how a person can communicate. This is usually, again, a very slow-growing cancer, usually squamous type cells if you look at those under a microscope. And this can be curable if we treat it early. Prognosis really depends on how advanced. Untreated cancer of the head and neck is fatal if not treated in 2 years. The cancer begins when the mucus in these areas is very irritated. It becomes tougher and thicker, and there's a particular genetic response that controls cell growth that are damaged, and they can be seen as white patchy lesions on red velvety patches. And unfortunately, with the head and the neck, it can spread to limbs, the muscle, and the bones. And your book does give some warning signs of head and neck cancer. A lot of times tobacco and alcohol may play a increased risk of acquiring these types of cancers, but the actual cause is unknown. Sometimes we see it in people who kind of abuse their voice, poor hygiene, or some of the research has shown that people that have GERDs, this may also be a cause or a risk factor. It starts off as problems with, phonation, impaired speaking. There's a lot of psychosocial aspect to it, especially when the families are aware that patients may have, abused alcohol or even smoking. Again, with any type of cancer, proper diagnosis with staging, tumor size, location, and the number of lymph nodes that are definitely involved. As I said, might be more geared to people that maybe chew tobacco, person that develops chronic laryngitis, exposure to irritants, as I said, infection with the human papillomavirus virus. We see about 54,000 new cases a year, about 13,000 deaths. Treatment, depending on the extent of the cancer, can be radiation and chemotherapy. Obviously, biopsies of the tumor itself to see what kind of cell growth the cancer is of. So that's head and neck cancer, okay? And then lastly, and these are some of the different interventions: radiation, chemo, cordectomy, and laryngectomy. And that brings us to laryngectomy, surgery, as well as talking about either partial or total laryngectomy. When we talk about to the extent of the cancer with these throat and neck cancers, might be cord stripping, cordectomy, or like I said before, a partial or a total laryngectomy. If it really involves a lot of the nodes, they're going to do what we call a laryngectomy with a radical neck. A partial laryngectomy, the trach is temporary, and that might be where we are able to catch it in the early stage, and the patient may need just some time to heal, so we have to provide a other airway, and that's where we do a partial laryngectomy, where they don't have to take out the whole structure. Cancer of the larynx is rather uncommon, and this is also one of those curable and treatable cancers if we detect it earlier than later. Squamous cell carcinoma is probably the most common malignancy, and what the person will begin to experience is hoarseness, change in voice, painful swallowing. They start to have foul breath and a lot of earache and maybe a palpable lump. They can diagnose it by a direct or indirect laryngoscopy, and of course with x-rays and biopsy. And of course, again, staging, tumor size and location, how many of the lymph nodes are involved, and the presence or absence of metastasis. And so we see about 10,000 new cases a year, men more than women, in the age group of about 50 to 70, and 50% more often in African Americans. Again, those carcinogens carcinogens such as tobacco, alcohol, and exposure to things like asbestos are some of the increased risk factors of acquiring cancer of the larynx. They usually categorize it in 3 categories, where it's supraglottic, which involves the false vocal cords, the glottic, which involves the true vocal cords, about 2/3 of the people, and then subglottic. 25 to 50% of people that acquire cancer of the larynx are present with involved lymph nodes, and it makes sense because it's in such a close proximity, being where the location of the cancer begins and how it spreads to the lymph nodes. Prognosis with small laryngeal cancers without evidence of spread to the lymph nodes is about 75 to 95%. Reoccurrence is about 2 to 3 years after diagnoses. Again, the hoarseness, sore throat, cough, burning in the throat, and lump in the neck. Those are some of the early signs, and later on we start seeing dysphagia, dyspnea, and talk about, what kind of surgical interventions that will happen. When they do a partial laryngectomy, it may include voice-sparing results for the patient who has an early laryngeal carcinoma, so they don't have to take out the whole voice box. With a complete laryngectomy, there'll be no voice and the need to breathe through a stoma in the lower neck. Okay, so very, very different types of treatments. Okay, and usually in those early stages when they catch it, as I said, a partial laryngectomy. If one vocal cord is involved, it's a very, very high cure rate. They won't have to take out the whole voice box, but maybe even with some reconstruction or one removal of one vocal cord, the person may really have a obvious voice quality change that they'll notice. Okay, even with the supraglottic, it's a temporary trach. Aspiration may be a problem because they have to learn a new way to swallow, because it does, but it will preserve the voice. But speech therapy will be required. With a hemilaryngectomy, one true and one false cord is removed. Now, a total laryngectomy, those are people that have been diagnosed in an advanced stage of the cancer, and all the laryngeal structures are removed, permanent loss of voice and change in airway, along with a radical neck dissection. Okay, and what that entails is quite an extensive surgery. We used to get these patients in ICU, and what will be done is they will have a neck dissection where lymph nodes, the sternocleidomastoid muscle, and the jugular vein are all removed. Even the 11th cranial nerve, the accessory cranial nerve, will be affected, which innervates in the trapezius and the sternocleidomastoid. Patients after the surgery will definitely have a shoulder drop. They'll need physical therapy. It's a very long and tedious surgery, lasts about 8 hours. And what they'll have in, besides, it isn't a typical tracheotomy that we learned with the last lecture, but it's a laryngectomy tube, which is very, very much different. It's shorter and the diameter is much wider than a trach tube. The one thing that you have to understand is, and this is very important, I hope this is what you take away from partial versus total laryngectomy, is with a total laryngectomy, the upper airway is separated from the throat and esophagus, and the trachea is brought out from the skin into the neck and sutured in place. So this creates a new stoma. So what is very important to know that it reduces the chances of aspiration. Okay. Many times after this extensive surgery, the patient will have to have reconstructive surgery, where they use tissue flaps from other areas of the body. We're watching for those post-op complications of hemorrhage, wound breakdown, pain management, and of course now a whole new way of speech and language therapy. If they've smoked, we really encourage smoking cessation, learning how to eat differently, about how to swallow differently. So this is a huge change in someone's life. Really has a lot of psychosocial issues associated with that. It really, involves not only our patients, but the support with their families also. Because obviously with speech therapy, communication will become a problem, and they can learn various methods of speech communication by either esophageal speech, artificial larynx, and even the tracheo-esophageal type of puncture to start making sounds and start the act of communicating. A lot of things can happen post-operatively. Respiratory distress with a lot of edema, hemorrhage, infection, aspiration. And not only do these people need to understand how many aspects of their life change as far as communication, nutrition, but they also have to learn about trach and stoma care, hygiene, safety measures, and things like that. So it really does take a lot of acceptance and maybe a change in a body image. So some of these people do need a lot of constant support to be able to deal with the drastic changes that have been made. And obviously with a very long and aggressive type surgery, the major priorities are airway maintenance and ventilation. And like I said before, these are many of the situations that can occur. These patients will be in ICU for a day or two just to make sure that there's no compromise of their airway. These are some of the different types of speech that may occur with these patients, and also putting them in contact with a lot of the community resources, so if they have questions about some of the equipment, that they know who to reach out to. It's very hard for people to manage this and know that this is something that's going to be permanent, and it may affect the way they feel about themselves as far as the changes in body imaging. So that pretty much concludes this chapter. If you have any questions, please let me know, and have a great day.